A very good evening to all. We'll be starting with the webinar now. The topic of this webinar is TIFO syndrome, and we are live on IAP India YouTube channel. We request all to subscribe to this channel to get regular notifications for the live webinars. If in case anyone has technical issues in Zoom, they can join in through the YouTube channel live stream as well. The speakers for today's session are Dr. Stephen Ford and Dr. Tejinder Singh. This session is being organized by IAP Thane district team. Now I request the IAP team to please take over.
Thank you, ma'am. Thanks a lot, and very good evening to one and all present here. So today's webinar, as we all know, the unique topic is T4 syndrome, and the resource person for this webinar, as ma'am has already mentioned, I'll just take the opportunity to give their brief introduction. The resource persons are Dr. Stephen Ford and Dr. Tejinder Singh. To talk about Dr. Stephen Ford, he is co-founder of the Global Initiative for Expert Manual Therapist, board certified orthopedic clinical therapist, fellow of the American Academy of Orthopedic Manual Physical Therapists. And Dr. Tejinder Singh is also the co-founder of Global Initiative for Expert Manual Therapist. He is the owner of Expert Manual Therapy and Doctor of Physical Therapy, a fellow of American Academy of Orthopedic Manual Physiotherapist, certified in dry needling. So, welcome, a warm welcome to the speakers. Also, I would briefly just give an introduction of the district team. Thane district team, we have Dr. S.V. Ramesh sir, who is the convener of Thane district. He's been practicing since more than 23 years, and he has multiple centers in the Mumbai, and the main head branch is in Mulund. And then we have Dr. Jay Pathak, also have an experience of more than 15 years, practicing in Mira Bhainder at Neo Physiotherapy Clinic. Then we have our convener, we have our treasurer, Dr. Pratiksha Dighe. She's also independent practitioner. She's practicing in multiple centers in Mira Bhainder. Then we have the EC members, including me, Dr. Suraj Shukla. I'm the in-charge principal of Barrister Nathpai College of Physiotherapy, and I'm also practicing at Arogyam Clinic. Then we have Dr. Ravi Prakash, who is also having two centers in Bhainder, one in the west and one in the east. So physio works, and is also having good experience in manual therapy and physical therapy. Then we have Dr. Gaurav Tripathi, who's practicing at Thane. He has his clinic in Tokalinaka. Then we have Dr. Nikita Ghatke, also practicing in Mira Bhainder. She has her own setup. So this was brief about the EC members of Thane district team. Then we go ahead with the concept behind today's topic, and we appreciate the initiative taken by Dr. Ravi Prakash. He has introduced these speakers to us, and we are really good to have both these speakers. And also, I would like to thank all the participants who are present for joining, and I hope cooperation for the further webinar. Thank you. I will welcome and hand over the further thing to the speakers.
Wonderful. Thank you. So to the IAP and especially the IAP of Thane, thank you guys so much for hosting this, for having us. We're really excited to be here. You guys, the world is evolving and changing, and information is becoming more available and at our fingertips. Research comes out every day. And when that happens, we are obligated as physiotherapists, as practitioners in a healthcare world, to access this literature. And it influences the way that we practice, and it makes us better, and it makes us safer, and it makes us more effective. But not only with the access of this information, like that's really important, but one of the issues that happens is with the access of the information, it makes recommendations for how we treat. And so our skill set has to rise to meet what the literature says. What good is it to know I should do a thoracic manipulation and a cervical manipulation on this patient in order to help their symptoms substantially if we don't have the skill set. And manual therapy skill set, whether it's dry needling, manipulations, muscle energy technique, is something that takes a while to develop. It's not something you can go to one weekend course and hope to master. It's just not. Very few people have that natural talent or that innate talent. And so we represent the global initiative for expert manual therapists. And our goal is to take something that we've accomplished. Obviously, we're still working on it. We're always improving ourselves. But to take something that we've accomplished and to share it with other physiotherapists around the world. And that's a skill set in manual therapy, corrective exercises, and the overall philosophy and approach to physiotherapy. And it's what we think is the best out there. When I was a young physiotherapist, I was a new physiotherapist, and this is with a doctorate from the USA, mind you. My first year practicing, I felt so insufficient. I felt there was so much to know and so much that I didn't know. I particularly had one patient who was a military gentleman, and he had periscapular pain. He had pain by his shoulder blade. And let me tell you, we mobilized thoracic spine, we worked on rhomboids, we worked on the traps, we worked on scapular mechanics, we worked on the neck, and patient was not getting better. So after 4 to 6 sessions, I called my mentor over. Her name was Kelly. And I said, Kelly, I don't know what to do with this patient. I've done everything and I cannot influence this patient's pain. Can you help me? And after 2 minutes of talking to the patient, she laid the patient down. She manipulated one of his ribs, and the patient got up and pain is gone. And that's the moment when I said, I need to know what she knows. I've got to get better, because otherwise I'll be having more patients that come and see me and I cannot treat them effectively. So that's when I embarked on my journey to become a specialist in orthopedics and to become a fellowship trained physiotherapist here in the United States. And Dr. Singh has done the same. And let me tell you that it's life-changing. It's life-changing. And we want to share that with physiotherapists around the world, this philosophy, this approach, this ability to get to the root of the problem and effectively, expediently, and safely get our patients better. Manual therapy is a powerful tool, but by itself, it's not enough. Manual therapy and corrective exercise, specific exercise, usually is the best combination of interventions that we do as physiotherapists. If you look at clinical practice guidelines set forth by the orthopedic sections of the USA, manual therapy and exercise is the best combination, not manual therapy alone, not exercises alone. There are other interventions that are making their way up, like dry needling. And so today we're hoping to do a demonstration of some manual therapy techniques, some dry needling techniques, and some corrective exercises after Dr. Singh lectures a little bit on T4 syndrome. T4 syndrome is interesting. In the fellowship program, our professors would often say, when talking about a condition, SI dysfunction, unilateral sacral extension, T4 syndrome, rib dysfunction, they would say, this diagnosis has seen you. You may not have seen it, but it has seen you. In other words, you might not have had the knowledge or the skill set to understand the patients coming in with T4 syndrome, but the patient came in with T4 syndrome. And so we have to get better. We always have to better ourselves, even Dr. Singh and myself. You can never learn everything there is to know about the human body, right? But that's our goal as Global Initiative Expert Manual Therapists. I'm going to turn it over to Dr. Singh, but before I do, I want you guys to know that we are starting our first cohort. We're already a course or two in. We do have rolling admissions for about 1 more week. Next weekend, we're going to be teaching, is it thoracic spine and ribs, Dr. Singh? Next weekend, we're going to be teaching thoracic spine and ribs. So it's not too late to join on if you guys like what you see today, if you like what you hear. Our fellowship, our program is 12 courses over the course of a year. Dr. Singh and I will be coming to India in September, October to be doing hands-on trainings in 1 or 2 cities in India. And so we hope that you guys will join our cohort. Courses are going to be online, and then we'll do some in person as well. And what we're trying to do is take the same knowledge that we've gained through specialization, through fellowship, the same knowledge and the same skill set, and impart that to anyone who's hungry, for anyone who's hungry to learn, to get the latest and the greatest as far as research goes, and not just how to pop and crack things, because there's practitioners all over that know how to pop and crack things, but we want to be the best, and we want to be the safest. And we want to have the most comfortable techniques for our patients, because there's so many techniques, and some techniques you watch someone do a cervical manipulation that would make you cringe. And there's other ways of doing it, osteopathic based ways that we teach that are minimal force, minimal discomfort for the patient, and it's more safe. So anyways, hopefully you guys can see some of that today. We call it the 3D appositional locking, or the component technique, or the maximal leverage technique. You guys will get a chance to see that today. So anyways, without any further ado, Dr. Singh, I'll turn it over to you.
Thank you, Dr. Ford, for the detailed introduction. So we're going to be talking about T4 syndrome, and it's a very fascinating diagnosis because our medical community does not validate it. So I'll give you a little bit of story, a little bit of history of how this diagnosis came along. And for 30 years, we don't know whether it's a theoretical concept or a clinical diagnosis. There has been a lot of studies published, but there is not even one randomized controlled trial. Okay, let me rephrase this. There is only one randomized controlled trial, which was done on asymptomatic patients. Okay, and we'll talk about that randomized controlled trial. So we're going to discuss this. I think this is a very, very fascinating diagnosis. So Karas in 2014 spoke about T4 syndrome in greater detail, and he says that whenever you're finding symptoms of T4 syndrome, you should look at 4 aspects. Why do you need to look at 4 aspects? We'll talk about that in detail. So you need to look at it as a musculoskeletal condition. You need to look at it as a biopsychosocial condition, neurophysiological condition, and then somatovisceral condition. So you're trying to dissect this T4 syndrome from 4 different aspects. And this comes out from all the research and all the literature that has been published since 1986. Okay. There have been theories about T4 syndrome. If you guys know about your sympathetic and parasympathetic system, your sympathetic system has a thoracolumbar outflow. You have a biomechanical fault at T4 that can alter the activity of sympathetic nervous system. Okay. Your upper extremity is supplied by sympathetic system of T3 to T6. And if something happens to sympathetic nervous system, or there is an overdrive or a hyperactivity of sympathetic nervous system, you can have symptoms that correlate to T4 syndrome. We're going to talk about this condition in greater detail. So we're going to talk about signs and symptoms first. So usually what will happen is your patient will present like this. They will tell you that I have pain in the scapular region. Okay. I have numbness and tingling in unilateral or bilateral hands. Okay. What we call it glove and stocking. Okay. So patient will present something like this: pain in scapular or parascapular region, and then you have forearm and hand paresthesia. Okay. The point is that forearm and hand paresthesia can happen in multiple conditions. We know so many conditions. We know about TOS, we know about radiculopathies, where you can have symptoms like this. There is a way to diagnose this. Okay. So we're going to talk about that. Okay. Usually your patient will present with transient paresthesia. Can anybody tell me what transient means, or what is transient? Anybody can tell me what transient means? We talk about transient ischemic attack, TIA. Can you tell me what transient means? You can write in the chat. Panelist.
Temporary, is it?
Temporary or short lasting? That's a good answer. So symptoms will come and go. Patient will have complete paresthesia of the hand, and then the symptoms will disappear on its own. Good. Because symptoms are present in the multiple dermatomes, we can think that it's non-dermatomal. Yeah, your patient is presenting with symptoms in more than one dermatome. Yeah, and some pain in thoracic spine. In some of the studies, they found that these patients also had pseudomotor and trophic changes, which means that they had increased or decreased sweating response. Yeah, and they also had skin changes, temperature changes. Yeah, and that's how they correlate this condition to the sympathetic system. Yeah, we're going to talk about various aspects of it. And there have been like more than 30 to 35 studies that has been published since 1986. The first study I think was published, it was not a study, it was a short article written by Maitland, and then followed by a short article that was written by, it was a textbook entry written by, I think, Bogduck in 1988, Migukin in 1986. So they spoke about this condition and they were trying to correlate hand symptoms with mobilization of T4. Okay. In 2014, Karas came up with his study, and he found out that this condition does not only have musculoskeletal attributes, but also have biopsychosocial attributes. Patient will present with loss of sleep, symptoms of anxiety. Okay. Some of the neurophysiological issues were symptoms of swelling. Patients will come up with swelling in the hands, conductance issue, skin changes, temperature changes. Okay. Symptoms of allodynia. Anybody can tell me what allodynia is? Anybody?
It's a condition of multiple pain. I mean,
allodynia is where your sensation is altered. A light touch can feel like sharp shooting pain, or a light touch can feel like stab. Okay. Or hypoalgesia. Okay.
Can I offer a distinction there, Dr. Singh?
Please do.
So hyperalgesia and allodynia are two different things. Hyperalgesia is when you're hypersensitive, right? So you touch something and a stimulus that would normally be painful is more painful. That's hyperalgesia. Allodynia happens when a non-painful stimulus creates pain. So touch that should not create pain creates pain. A light wind blowing over someone's hand or someone's forearm is causing pain. Mild changes in temperature causes pain. So it's when a non-painful stimulus causes pain, and that's unusual, and that alerts us to know that there's something unusual going on.
Okay. Thank you, Dr. Ford. So we know the biopsychosocial components, we know the neurophysiological components. There were also somatovisceral components that actually confused a lot of researchers. But if you look at it, your heart is supplied by T2 to T4. Your esophagus is supplied by T1 to T10. These patients were presenting with head and neck pain and headaches. Can anybody tell me why upper thoracic syndrome or T4 syndrome patient will have headaches? Anybody? And this comes down to your basic anatomy. Anybody? This is a sympathetic nervous system problem. It's an SNS hyperactive issue. Why these patients are having headaches? So your head and neck and your head specifically is supplied by T1, T2. So possibly if you have issues in T3, T4 or T4, T5, you can also have issues in T1, T2. Simultaneously, we always talk about region interdependence. Yes, absolutely. T1, T2. Yeah. And then there's a associated autonomic nervous system dysfunction. Okay. So this is more of an autonomous nervous system disorder. Okay. We'll talk about a case study where we're going to discuss in detail how you can actually diagnose this and how you can differentially separate this from other conditions. because there are certain conditions that mimic exactly like this. Okay. Yeah. Let's do a little literature review. And then, so this is a very, very fascinating diagnosis because a lot of noise has been created around T4 syndrome, but there is not even one randomized controlled trial on patients with T4 syndrome. Joyce in 2010 published a study on asymptomatic patients. So what he did was he took like 36 subjects and he was trying to see the changes in the hand by manipulating T3, T4, T4, T5. And he was able to produce changes in conductance, changes in temperature by manipulating the thoracic spine. But that's the only randomized control trial we have. Study by Melik and Melik. And this is the only study that has been published by medical doctors. Most of these studies are published by osteopaths, chiropractors, manual therapists. And it's good to see manual therapists publishing stuff because, I mean, we see a lot of stuff in the clinic while we're practicing, especially when we've been practicing for a long time. And sometimes it's hard to back those findings with solid clinical research. So Melik and Melik, what they did were, they found these patients with hand symptoms. I think they had like only 4 patients, and this was an expert review. And what they did was they gave a epidural injection at T4, T5, T3, T4, and they were able to help the patients with these bilateral hand numbness. Okay, so this was the only medical study published. And I'm talking about last 30 years. Maitland published the first study in 1986. So we're talking about 30, 35 years of research. And these are the main articles you should be looking at. I think the best article, according to me, is by Karas and Pinon. This is a systemic review and which talks about all these studies. Okay. So if you're looking to know more about this condition, make sure that you read this article. This is a beautiful article. I can share on the group as well so that you have information about the condition. Okay. Okay, let's talk about the case study. And this is a patient I saw in the clinic. And I had a student at that time. So this is a fascinating patient. Okay, so my patient was a 44-year-old female. She presented with pain from distal elbow to the hand bilaterally. Okay, and numbness in the hands. Okay, and symptoms started with 4 weeks ago with no clear history. And patient also, because patient had more symptoms on the left side, she also had ECG done, which was negative. And she went to the emergency room because if you have numbness from here to here, I mean, bilaterally, it will confuse a lot of medical practitioners, right? She also had some left-sided occipital headaches, some left cervicoscapular pain, okay? Our physical exam showed some restriction in extension, mild restriction in flexion, moderate to severe restriction on the left side, moderate restriction on the right side of rotation, and then bilateral restriction in side bending. So basically you have restriction in all directions, okay? And people who have gone through our courses, they might understand the terminology a little bit better than other people, but we'll try to simplify this for you. Okay. So we did a physical exam and we found like opening and closing dysfunctions at multiple segments. We found like a MIA dysfunction at C0, C1 on the left side and lips dysfunction on the right side. MIA is medial inferior anterior. When your sympathetic system is affected, you can have numbness, burning, tingling, anything. I mean, not necessarily you'll have all the symptoms that should be present with sympathetic system hyperactivity. Okay. So this patient also had a closing dysfunction at C2, C3, a closing dysfunction at C5, C6, and Dr. Ford will demonstrate all these techniques. Okay. Patient had a first rib dysfunction, third and fourth rib dysfunction. I think we have spoken about this. Third and fourth rib springing cause symptoms in the medial elbow. And we always talk about how your intercostal nerves can supply the medial cutaneous nerve of the forearm. So this patient also had some entrapment of intercostal nerves. Okay. And also severe hypermobility at T2, T3, T4, T5. Symptoms in the bilateral hand reproduced with T3, T4, T5 springing. So When we did like gentle PAs, because this patient had a lot of pain, so we did gentle PAs, we were able to reproduce patient's symptoms in the hand. Okay. Okay. The interesting thing is, because it is an autonomic nervous system problem, usually you'll find no neurological signs. Your dermatome testing and myotome testing will be normal. PA is posterior anterior glides. Basically, you're doing a posterior anterior glide. Okay. Sperling's test was negative. We did the tendon reflexes, everything was fine. Okay. So no motor issues, no sensory issues. Another condition that can cause symptoms down the arm, your neurovascular, can affect the neurovascular chain, is your thoracic outlet syndrome. Okay. Your Roos, Adson, and Wrights were negative. Okay. If you know about thoracic outlet syndrome. So we ruled out other findings. We ruled out sensory issues, nerve root issues. And some people call T4 syndrome also has a diagnosis of exclusion. You try to find everything else, and then if nothing makes sense, then it's T4 syndrome. You can always palpate T4, T3 in a segment above and segment below. Yeah. Yeah. Another thing I want to actually talk about this condition is that, let's go back to this. Okay. Can anybody tell me why the patient has glove and stocking kind of symptoms, or like whole hand is getting impacted? Anybody? We know it's a sympathetic nervous system problem. In diabetes, you guys see glove and stocking kind of presentation. Can anybody tell me why you have like the whole hand involvement, which also happens in diabetes? Because you also have to understand anatomically what is getting affected if you're trying to treat something, right? Anybody? Why the person has symptoms in the whole hand, not on the medial hand or lateral hand? Why does the patient have symptoms in the whole hand? Anybody? Okay. You're missing an important component. I mean, because the whole hand is getting impacted, it's not a dermatomal or nerve root issue. Neither it's a peripheral nerve issue. It is not affecting the nerve root, no. It is not an irritation of the root. Because you're seeing symptoms across multiple dermatomes, it cannot be a nerve root issue. Anybody? I'm looking for the right word. And you see this in diabetes all the time. If you've seen patients with diabetic neuropathy, where they present with numbness in the whole leg or whole feet or both hands, right? Anybody? Okay, so let me tell you, this is a thickening of the nerve. No, okay. So yes, there is an autonomic nervous system dysfunction, but this is an axonal issue. It's an axonal problem. The whole axon, a preganglionic axon, is getting affected, and that's why the patient has symptoms. And whenever we do manipulations or whenever we mobilize it, that's what we are impacting. We are causing the down regulation of the nervous system. Okay. So this is an axonal issue. Okay. Okay. Let's talk about the treatment techniques. And we can talk about a lot of treatment techniques, but we're going to talk about the basic ones. So I will show you some videos and some techniques. So this is a technique. We spoke about how the patient has right LPS dysfunction, where the occiput was not able to go MIA. So the patient is in sitting position. And then what you do is you trying to thrust the occiput forward. Okay, you're blocking the arch of C1, and you're doing a little thrust there. And I think Dr. Ford will show you the setup.
Yes.
Okay, I'll go through these techniques very quickly, and then Dr. Ford can just jump and show you the setup. And this is to correct when your occiput is not able to go posteriorly. Okay. You stand on the opposite side. Your hand is on the posterior arch C1, and then you're trying to thrust it posteriorly. Yeah. And then this is a C2, C3 dysfunction. You're trying to manipulate across the opposite eye. Yeah. Dr. Ford, just show these three techniques first, and then
Sure.
we'll talk about thoracic spine. Okay.
Ram, you ready to go? All right, let me start my video. Let me share my screen. Okay. Dr. Singh, is it better for me to share my screen for video purposes? Or
Yes,
would it
please.
be better to?
You can
Okay.
share it.
Okay, so if you'll stop screen share, then I can share mine. All right. We're gonna have a seat just in that chair right there. Okay, so if I want to make my video big now. All right, what's the best way for me to make my video larger?
I think just have to click on it. I think. Yeah. Yep. Just click on it. I think you'll be able to.
That's actually not this.
Is there a way, you guys can, is there a way that I can make my video larger for everyone?
I think if you want to show yourself, don't use screen share.
Okay, so let me pause the share.
I think I can share the screen, and then you can just show the three techniques we discussed.
Okay. So can you guys see me okay?
Yes.
Okay. All right, you guys can see okay? Sorry, guys, give me just a sec. There we go. Okay. All right. Okay, so in the first technique, the occiput is stuck in Mia. Is that correct, Dr. Singh? The first one? Okay.
You can
So
show me.
So basically, the occipital condyle is stuck in this position. It's stuck Mia, medial, inferior, anterior. And we need the occipital condyle to be able to move lips, lateral, posterior, and superior. Okay, so it's stuck here. So for this technique, we're going to take the skull and the occipital condyle, and we're going to thrust occipital condyle lips just like that. So in order to do that, we need to stabilize C1 and then wrap around the head, kind of like a turban grip. Okay. I'm going to rock his head into me. So I'm going to lean the patient over into me, creating a little bit of side bend. I'm going to engage the arch of C1. Okay, so I've got C1 here, the palpation of which, we teach in our courses, but to be in the exact right place you need to be is important. So there's C1, side bend into me. We're going to distract a little bit. I'm going to rotate his head until we feel the bind, till we feel the barrier, and then 1, 2, 3, thrust. Okay. For the lips, for the opposite, let's come to the other side. So in the lips manipulation, the occipital condyle is stuck lateral, posterior, superior. Okay, it's stuck lateral, posterior, superior, which means that if the patient wanted to extend the neck, do cranial extension, it's not happening. Okay, so we need to help the occipital condyle to move medial, inferior, and anterior. So the manipulation is forcing occipital condyle, medial, inferior, anterior. So we've got to block C1 from the anterior aspect, wrap around the head in a similar fashion, side bend patient into me, distract patient superiorly, and then block C1, and it's going to be a rotation, 1, 2, 3. It's going to be a rotation like that. Okay, 1, 2, 3. Okay, and that's the Mia manipulation. Taking the occipital condyle, medial, inferior, anterior. Let's go look at the next set of interventions. So Ram, if you want to come on over here. C2, 3 distraction. C2, 3 distraction, Dr. Singh. So come lay on your back for me. Let's have the patient laying on their back, head on a pillow. If their head is not on a pillow, they'll be in cervical extension, and we don't necessarily want that. I want to control exactly what we're doing. Okay. So for C2, 3 distraction, you've got to be able to find C2. C2 is the easiest landmark in the neck to find, because if you start at the midline of the neck and you start at the base of the occiput and then you work your way down, C2 is the first spinous process that you're going to be able to palpate, and it's large. C1 has a tiny, tiny, tiny spinous process. Really, it's virtually not even there. So there's going to be occiput. There's going to be a soft gap where C1 arch is, and then you're going to feel a prominent spinous process. The first one you feel is C2. So that's our landmark. So I'm going to cradle the head. I'm going to engage the articular pillar of C2. So I palpate C2 spinous process, and then I just wrap a little bit lateral from there. Nice soft contact. And for C2 manipulation, the direction of thrust is towards the opposite eye. For C1, it's ipsilateral eye, and for occiput, it's straight superior. So occiput superior, C1 is the same eye, C2 is opposite eye. So grab onto C2. I'm going to hug his head, so I've got good control of his head. I'm going to angle my body in the direction of the thrust, just towards the opposite eye. I'm going to put my eyes in the direction of the thrust, compress everything, get the skin nice and tight, hold everything, give some mini thrusts, 1, 2, 3, and then a nice big thrust, grade 5. Okay? Okay.
Dr. Ford, I'm going to share the screen and go through the three or four slides quickly, and then you can show the stuff. Okay.
Sounds good.
So,
Thanks.
so these could be secondary dysfunctions, and then you can also do a down and back manipulation or a closing manipulation for C5, C6. And there are various ways to do it. Patient is in supine lying. You do a little side glide, little side bend, and then you do a little rotational thrust. Okay, and Dr. Ford will show you this as well. You can also do mid-thoracic mobilizations or upper thoracic mobilizations, T2 to T4. Patient is in sitting, resting their forehead on the therapist's chest. Your hands are in the interspinous space, and then you're trying to create extension. Okay, and I think Dr. Ford will demonstrate. This is a very straightforward technique. Because mind you, the primary dysfunction is in thoracic spine, T3, T4, T4, T5. So you definitely have to mobilize that. Okay. And then you also have to mobilize the upper cervical, because you can have secondary dysfunctions in the upper cervical spine. Okay. Okay, prone position, you can do a thoracic manip. Yeah, you can have pisiform on the facet of the dysfunctional side, opposite hand stabilizer transverse process of the opposite side, and then you can thrust anterior, lateral, inferior. Very straightforward technique. Yeah. Okay, you can do this. Okay. And then this is a most common technique we use to improve the down regulation of the upper extremity. A mid-thoracic manip, patient is in supine lying. You lock the patient's spinous process, flex to the segment, and then thrust down. Just lock to the segment, and then you just do a little thrust. Very easy technique. And you're trying to create the segmental extension at that segment. Manipulation, I think, works really well because we know it's a sympathetic system problem, and a little thrust can just create that down regulation, sympathetic down regulation. Yep. Dr. Ford, let's show these 4 techniques. Okay. C5,
Sure.
C6, and then you can do a couple of thoracic manipulations and a thoracic mobilization.
Sure.
Thoracic mobility. Yep. Okay. Let me stop sharing for you so that you can. Yeah.
Sounds good. All right. We good? We all right? All right. So if you guys want to pin my video and make it big, Dr. Singh, if you'll just call out the techniques one at a time. What's our next one? The closing?
C5, C6 closing manipulation. Yes, sir.
Okay, cool. The neck. So a lot of therapists are apprehensive to do the neck, as you should be. I think you should have a healthy amount of fear when it comes to manipulating a neck, because it's one of the places where we can really hurt somebody. Neck manipulations require maximal amount of preciseness in terms of which joint are you at. There's a whole 5-step screening process that we put patients through before we manipulate a neck. We're not going to go into great detail, but basically we want to do expert history taking. Was there mechanism of injury? Was there trauma? What are the signs and symptoms? And then if the patient passes through that, then we need to check for upper cervical instability by doing alar ligament test, transverse ligament of Atlas test. We'll do a Jefferson's compression fracture test and rule those things out. Vertebral artery insufficiency test, followed by putting the patient in the position where their pain is reproduced and check their symptoms, and then put them in the manipulative position, the position right before we manipulate their neck, and ask about their symptoms. And if they have unusual symptoms, we call it the 5 Ds and the 3 Ns, the 5 Ds and the 3 Ns. The 5 Ds are dizziness, double vision, or diplopia, dysphagia, difficulty swallowing, dysphagia, difficulty speaking, and drop attacks, which would be like fainting. Okay. And I've had patients with any and all of these symptoms before. I'm sure you guys have too. And then the 3 Ns are nystagmus of the eyes, right? That's a red flag. Numbness of the lips and tongue, and nystagmus, numbness, and
Numbness of the face. No.
numbness of the face, nystagmus. There's one more. I'll think of it in a second, but we have to run them through this screening. Huh?
Nausea.
Nausea. Thank you. Haven't had enough coffee yet, apparently. So we run them through the screening process. And if they have these kind of signs and symptoms, if they have upper cervical instability, vertebral artery insufficiency, then it's a red flag, and you will not manipulate that patient's neck. And this is what makes us different from chiropractors, because we're not going to pop a neck that shouldn't be popped. So we're safe. PT profession has never killed anybody doing neck manipulation. Unfortunately, the opposite is true of the chiropractic profession and some other people that do popping and cracking just for fun. If you try to manipulate every single neck that comes in your clinic, there's going to be someone that you should not have done it on, right? And every now and again, there's a story in the news. In America recently, there was a very famous news personality who went to a chiropractor with a headache, and the chiropractor did not put them through an appropriate screening. manipulated that patient and they stroked out later. And the chiropractor did not do good screening. So anyways, so it's a healthy amount of fear when we're manipulating a neck, right? But under the right circumstances, it's a great technique. It's a great tool. I manipulate necks all day long. We do it safely, effectively. And so anyways, here's C5, C6. So the cool thing about neck manipulations, if I wanted to manipulate this neck, if I wanted to do an opening manipulation or an up and forward manipulation, the only difference between that and a closing or a down and back manipulation is the position of the neck. So if I have the patient biased in flexion and I do my manipulation, then what's going to happen is we're going to perform an up and forward or an opening manipulation on this side of the neck. If I have my patient in more extension, then when I manipulate the neck, we're going to get a down and back manipulation on this side. When do we do the different techniques? It depends, right? If there's a specific dysfunction, which we will teach, if there's a specific dysfunction, we want to treat it with a specific technique. If a patient has severe nerve root irritation on this side of the neck, I'm probably not going to force the facet down and back on this side of the neck because that will light it up. And so there is clinical reasoning as to which technique we would select. Again, we would teach that. So let's do a down and back for C5, C6 on the right. How do we find C6? Move the head into flexion extension. When you move the head and when you move the neck into extension, the C6 spinous process tucks under and disappears. So there's C6. Boom. Okay. I'm going to wrap around the articular pillar of C5. So I've got C5. I'm going to create a little bit of extension. The moment that I do that, I've engaged that segment. So now that segment's mine. I've wrapped around it. I'm holding that segment. I have control of that segment. We're going to side bend, side glide, rotate until there's a barrier. And look, I've already got a barrier at about 15 degrees of neck rotation. So generally speaking, we don't want to do neck manipulations at the end range. I'm not trying to do a manipulation here. Okay. That's not what we want. If we'll use multiple levers, compression, extension, side bend, side glide, then I can get a barrier with only 15 degrees of rotation, which makes it a very safe technique. Okay. So there we are. We've engaged the barrier. 1, 2, 3, thrust. We can do the other side. Extension, side glide, side bend.
Super technique, Dr. Ford.
Nice. Thank you.
He needed it. He needed it. He needed C5 minute on the right. Sitting in the
I've been practicing.
All
right, cool. So that was C5, C6. What's next, Dr. Singh?
You can show thoracic mobilization sitting.
Thoracic mobs. All right, hop up, Ram. Come on over here. Every time I think of this technique, I think of you, Dr. Singh, because you're the first one I saw doing it. All right, have a seat. So what we're going to do is we're going to put the patient's hands like this on the head. And then I'm going to bring your hands onto my chest. Okay. Obviously, if you're a physiotherapist and you're a woman, you might want to seek an alternative technique. There's plenty of them. My fingertips are going to select which segment I want. So here's C7. So if I want to emphasize the leverage at C7, I'll put my fingertips just lateral to C7 spinous process. And then I'm going to have him lean forward. And as he does, look what I'm doing with his elbows. I'm moving his elbows up and out. And that's going to really create a nice fulcrum where my fingertips are. See that? Look at that. And then we can come down, T2. We can come down a little bit more to T3 and T4. We can do some springing there. Okay. This is a great technique. After I've done some of these, you can have the patient do them independently. Put your fingertips at the base of your neck. And I want you to put pressure kind of like I did. So let's put pressure. T4 syndrome, C7, T1, T2, T3, T4. Okay. So right there, elbows and head down. That's where you start. Elbows and head up. And put a little bit of pressure here. And then down. So after I've mobilized the patient, I'm going to give them this exercise for home, self-treatment, right? We believe in empowering our patients. That's one of the things that GEM does very well, that we do really well and teach really well, is not just creating patient dependence, but we want to give them tools that they can begin to treat themselves at home, and it helps them to get better faster, right? Not all patients are going to do what you give them, but if you can show them the value of it, then they will, right? If you just give them an exercise for nothing, they're not going to do it. But if you can show them the value, they can feel the relief, they're more likely to do it at home. So this is self cervicothoracic mobilization, self CT junction mobilization. What's our next technique, Dr. Singh?
Show us like upper thoracic manipulation, supine and then prone.
One of the cool things about going through fellowship program and orthopedic specialization and what we teach at GEM is there's so many different ways to manipulate the same segment, right? So we can do thoracic spine and CT. Well, I can do it sitting, we can do it laying down, we can do it prone, we can do it supine, we can do it side lying, we can do it sitting. So we're going to demonstrate just one or two techniques, but just recognize that there's many, many, many. And depending on the therapist, the patient, what's going on with the patient, what positions they're comfortable in, you would have multiple techniques to select from if you're able to learn the various techniques. Come lay on your stomach. Put your, okay. So I'm going to demonstrate a little bit different than the one Dr. Singh did. If you guys will remember that the facets in thoracic spine are oriented at about a 60-degree decline, which means that if we want to manipulate thoracic spine, we can do manipulator dip like this. Boom. All right, we can do that technique. You can also come from superior and give about a 60-degree thrust anterior and superior. So hands next to each other. I've engaged the shirt, compression, I've engaged the skin. Now I'm going to move the skin. The skin's locked out. So now I have no more wiggle room, right? But if I don't lock out the skin, this is where I am. So let's roll the skin nice and tight. Thrust, thrust, thrust. That was a mid-thoracic. I'll show you guys how I like to do upper thoracic and CT. Flip over on your back. That's perfect. Yeah. In the thoracic spine, right. So here's our neck, right? Cervical spine has a lordotic curvature. And then usually at the CT junction, we've got this little kyphotic curvature, right? And the thoracic spine itself normally has a little bit of a kyphotic curvature. So to manipulate CT junction, usually we have to put more of a fulcrum underneath the CT junction. So under thoracic spine, whereas you can use like a flat hand or a collapsible fist directly under the spinous processes, in the CT junction, you cannot use a flat hand. You really need to use a big fulcrum like a collapsible fist. So a collapsible fist, we're not making a fist like that, right? We're actually going to place the fingers like that. And watch what happens when I press on my hand. See how it has some give? So it has some give. It can move a little bit. So this is a soft fist or a collapsible fist. It'll be much more comfortable for the patient than if you make a fist like that, like a hard fist. Okay, so just pointing that out there. Okay, Ram, scoot over close to me. Give yourself a big hug. This is how there's 10 different ways to pop CT junction. This is the way that I usually do it. Opposite arm on top, bottom arm there. Arms are never crossed. We don't want to cross the arms like this. Why don't you want to cross the arm like that? Because if you push hard enough on that ulna and that radius, that's going to hurt, right? So one arm on top, one arm on the bottom. Roll the patient towards yourself. And then you can palpate spinous processes. And I'm going to park my fist right under my target segment. Let's say you want to manipulate T3, T4. I'm going to park my fist under T4. And the thrust that I give, I'm blocking T4, and the thrust that I give is going to move T3 on T4. All right. In the thoracic spine and CT junction, usually we just want to manipulate multiple segments at a time. And so we don't have to be ultra specific, but I think you should be, because you want to make sure the segment in question gets manipulated. If you hear 10 pops, you don't know what popped and what didn't pop. And so it's important that if we're trying to target T2 or T3, T3 or T4, that you park your fist at the inferior segment, and the manipulation will occur between, for example, if I block T4, the manipulation will occur for sure at T3, T4. We might get others. So collapsible fist at T4. My forearm is engaging his elbow. And look at what happens to my solar plexus. So I'm not putting my body on top of his pokey elbows. Okay, I'm not doing that. I'm actually going to wrap his elbows with my forearm, and I can put my body on top of my own soft arm. Okay, now, the first thing we have to do is we have to engage the barrier. So if I flex the spine, that moves my pressure lower down his spine. If I extend the spine and bring his elbows and my body right above my fist, I can feel pressure on my hand. No pressure on my hand, pressure on my hand. So your goal is to build maximal pressure at your hand where the fulcrum is. And once you build maximal pressure, you can say, breathe out, compress, 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 and then thrust. Okay, let's go again. Engage pressure. All right, Ram, go ahead and breathe in, breathe out. Compress, 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 and thrust. Okay. What's next?
I have few mobility exercises you can show.
Okay. I'll
So
let you show them in the slideshow. We'll wrap up in a couple of minutes.
then some of the upper thoracic mobilizations, you can do it on a foam roller. I think you already showed this. And then I like doing this because you can mobilize thoracic spine in both flexion and extension. So that's about it.
Okay, so let's do this. Let me do the dry needling on my patient, and then I'll let my patient go, and then I can demonstrate the mobility exercises. Does that sound all right?
Sure.
All right. Do you mind taking your shirt off and laying on your stomach? GEM teaches a dry needling certification course, and that's going to be one of our hands-on trainings when we come to India. I think that dry needling is very interesting because anybody can do it. Anybody can pick up needles and start needling things, but it can be very misleading. If you just want to needle all the muscles that hurt, you just want to needle IT band, you want to needle upper traps and stuff like that, that's cool. And it's going to help because you're addressing a trigger point. But at GEM, we always, always, always harp on, emphasize, remind, educate. We must get to the root of the problem. And when we get muscle knots, muscle spasms, muscle tension, the muscles themselves are not usually primary. They're not the primary problem. What's the primary problem? Joint dysfunction, posture, poor mechanics, poor ergonomics. This is why the muscles are angry. And so as a physiotherapist, if you want to be a basic physiotherapist, you address what you see, which is this muscle hurts, this thing hurts, that thing hurts there. If you want to be a basic physical therapist, if you want to be an advanced expert therapist, you need to see that for what it is. IT band is not the culprit. It's low back. It's SI dysfunction. It's weakness of the hip. It's what the patient's doing. It's how they're running. It's how they're sitting, right? Carpal tunnel syndrome. Problem is not here. 99% of the time, the problem is not here. The symptoms are here, but the problem is not here. The problem is at the neck. Upper trapezius is not his fault. It's not levator scapulae's fault. That's a posture, ergonomics, joint dysfunction issue. And that's what we've got to get to the root to. So dry needling is great for an expert therapist because you can address the sequelae, or you can address secondary, tertiary, quaternary problems, but we've got to get to the primary, okay? For me personally, I like to start at the joints and then work my way out. So now that we've done the joint work, now we're going to come and address some of the muscle tension, muscle spasm. If we've got some trigger points, we can address that. And it makes for a much more holistic and effective treatment. This is why things like massage don't fix people's pain, right? If it's just tired muscles, yes, massage is wonderful. But if there's a joint dysfunction, if there's a posture problem, ergonomics problem, massage will make it feel better temporarily, but it doesn't fix the problem. If you go to Dr. Singh's business website, Google page or my Google page, ACE Physical Therapy and Wellness or Expert Manual Therapy in Austin, and you read the Google reviews, you're going to see how many patients have come to us that have gone to chiropractors, acupuncturists, other physiotherapists, doctors, surgeries, all these things, and they've not had their problem treated. And they see us and we're able to affect a positive change. We're able to get them better, sometimes after 2 or 3 sessions, sometimes after 1 session, because the advanced training that we've gone through and that we're offering gives you that clarity. The mentality changes. We're not just looking at the muscle that hurts. We've got to get the bigger picture. Anyways, so that's my caveat with dry needling. It's a great tool, but it's only as good as the user. Okay, it's only as good as the user. All right, so I'm going to do a quick dry needling treatment on Ram here. If this was my patient with T4 syndrome, I would probably not elect to use dry needling in my first 2 or 3 sessions. I would do joint work. I would give home exercises, and we would see how the patient is doing. If the symptoms are stubborn or slow to go away, then I'll employ dry needling in this patient. Just me personally. You could do dry needling on the first day. That's not wrong. I just prefer not to use it unless I have to. So let me do a quick dry needling here. What we're going to do, we're going to come to T3, T4. Really, we'll probably just do from CT junction down. Okay. And we're going to needle the paraspinals in the target area. We'll go ahead and do upper traps and levator scapulae. We'll do cervical paraspinals, and we'll do the suboccipitals. That's what I would do if I was doing dry needling for a patient with T4 syndrome. So we'll demonstrate that. I'm not going to do a very lengthy treatment here. We'll probably just do like 4 or 5 sticks on each side. Ram, you good?
Yeah.
Okay. So for dry needling, there are some contraindications. You guys would need to check that with your patient. You would want to get a verbal consent or a written consent, permission from your patient to treat them. And I'm not going to go over the contraindications for dry needling, but you would want to check that as well, right? Clotting disorders, needle phobia. There's some different things like that that we would want to not do needling on. Step 1. We're going to wipe the area with an alcohol wipe. Okay, so anywhere we're going to treat, we're going to use either a cotton ball with a little bit of alcohol or some kind of sanitizing wipe. There we go. Going to wash hands and glove up. Patient is comfortable. I've got the patient laying down. Okay, so if he doesn't feel good, he's in a good position. If I did this sitting up and he started feeling faint, then I have to catch him while he's got needles in him. That's not good. So we always have the patient in maximal comfortable position. Okay, you guys ready? All right. Let's do our palpation, our landmarks. Being able to identify where you are in space is so important. That's a big part of being a manual therapist. In fact, it's foundational to being a manual therapist is good palpation and anatomy. So I can feel C7. C6 is the drop off. Look at that. Boom. C6. C6, C7, C6, C7. C7 and T1 are very close. There's C7. Here's T1. I'm going to step my fingers down. Now I've got T1, and here's T2. Here's T2. Here's T3. T3 and T4. Okay, so this is my treatment window for T4 syndrome. I'm going to use smaller needles, shorter needles. There's not a lot of depth here. You can use longer needles and have extra, that's fine. But since there's not a lot of depth, I'm going to come about 1 finger's width away from the spinous process. So there's a spinous process. There's 1 finger's width. And I need to stay within this window from the spinous process. So there's a small window there. I've just outlined it with my fingers. That's my window. And I'm not going to insert the needle directly anterior. We're going to angle the needle back towards the spine because I want to land on the articular pillar. Okay, there's one. I don't know if you guys can see that or not.
I think it's visible, Dr. Ford.
Great. There's the spinous process. There's 1 finger's width. There's my window. So I'm going to put the needle here. I'm going to put the needle in that window there. Okay. And then I'm going to angle the needle back towards the spine. Okay. So I would do this from probably CT junction down to at least T4. Okay, on both sides. For the sake of time and demonstration, I'm not going to do all of that. But you guys get the idea. Now I'm going to get a bigger needle for upper traps. Okay, so let's take a look at upper traps. Upper trapezius, we don't want to needle it down towards the lungs, right? Upper trapezius is one of the muscles that we like to pinch and reflect up off of the body. And I'm going to have these 2 fingers on the other side of upper traps. And those 2 fingers that are here, that's going to be my backdrop. So in other words, that's where I'm angling the needle towards. Let's pinch around at upper traps. I usually break it down into 2 or 3 sections. And I say, in this section over here, how does it feel? Okay, we've got a little bit of tension there. In the mid substance, yeah, a little bit of tension there. And over here, a little bit of tension, but not as much. So more zone 1 and zone 2, if you will. So let's do zone 2. So I'm gonna pinch upper traps, put my needle on, tap it in. We're going to insert, and there you go, the muscle twitches. We're going to insert until I feel the needle approximate the skin, and I can actually feel it with this finger. The skin is very thick, so the needle's not just going to come right through, so I can feel the needle right next to my finger. That's how we know we've done the whole girth of the muscle. Let's see if we can get a couple of twitches out of it. Hopefully you guys can see we're getting some couple of little twitches here and there. So that's mid substance of upper traps. I'm not going to leave the needle in and let go of the skin. I'm going to take the needle out first. Now let go. Let's come and do the medial upper traps. Right there. And consequently, if I do it just right, we can also get levator scap. We can also get levator scap. So I'm going to pinch here. We're going to get upper trapezius and levator scapulae here. This is a great spot. Okay. I'm going to piston a little bit. And you can see I can roll the muscle around and hit different areas of the muscle by changing the angle of the needle, by rolling the skin in my fingers. I can move the muscle around a little bit and hit different areas of it. Okay. I'm going to dispose of this needle. Need to dispose of needles in a sharps container. This needle has contacted someone's blood. This can't go in the trash can or the rubbish bin. You must find a sharps container. Okay. Or some people will use like a plastic bottle and put their needles in a plastic bottle and put the lid on. But I think sharps container is better if you can. All right, so now we're going to come back to the neck. And we're almost done, Ram. You're being a champ. If you look at the anatomy on the posterior side of the occiput, there's basically 3 suboccipital muscles per side. And so I like to break it into 3 zones for that reason. Just like I do upper traps, I kind of break the suboccipitals into 3 zones. So let's do suboccipitals now. Okay, here's the middle of the neck. Here is the mastoid process. And so if we divide that into 3, 1, 2, 3, I've got 3 different suboccipital muscles that we can hit. You can check the anatomy. Okay, so first thing I'm going to do is from midline, I'm going to come just lateral to midline. And look at that. Don't know if you can see it or not, but my finger is twanging over what feels like a bass guitar string. All right. So here's my first stick into that taut muscle. The needle is angled up towards the eyes because we don't want to go straight anterior. We actually want to land on the occiput. So you'll pierce the muscle. You'll land on the occiput. You can do what's called periosteal pecking, where we feel the occiput. I can feel that we're on the occiput and we peck the bone, peck, 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 peck the bone. That's a little bit more aggressive technique. If my patient was not responding well, or if they were not making the progress I wanted them to, then I would get more aggressive with my needling treatment. My first treatment is always very gentle, very light. We're going to find the worst 2 or 3 trigger points, the worst 2 or 3 spots that need to be addressed. And I'll just do 1 stick in each of those spots and see how the patient responds. And if they respond well, we can do more in subsequent sessions. Some people don't mind the needling. Some people really don't like it. Then I'm going to come into the next zone. So we did zone 1. I'm going to come to the next zone. And there's my suboccipital right there. I can feel that. Angle it up towards the skull at a sharp angle, about 45 to 60 degrees. We've pierced the muscle and we've landed on the skull. Okay. We're going to do 1 more. And I would do this on both sides. Just for the sake of time today, I'm just going to demonstrate this one side. Okay. All right. In our final zone, which is going to be medial to mastoid process, right there. Needle on, tap it in, remove the sheath, and insert to depth. There we go. Okay. And we could, like I said, we could have done the same thing here. We could have also, just like we did with these 2 needles here and here, we can follow these up and hit the cervical paraspinals. Usually I do. Usually I'll check cervical spine. And if there's a trigger point or a muscle knot or some tenderness or something, then I'll want to address that tissue dysfunction with the needles. Dry needling, the moment you put the needle in, the effect that the needle is going to have has been set into motion. So in acupuncture, a patient will lay with the needles in them for 20 minutes, 30 minutes, 40 minutes. In dry needling, because of research and literature, we know the moment you put the needle in, every single thing that needle is going to do for the patient has already happened. So do we need to leave the needles in for 20 or 30 minutes? No. Insert, twitch the muscle, come out, you're done. So dry needling is really beautiful because you only need to spend a few minutes doing it. It's not going to take up a whole session. It's not going to replace manual therapy. It's not going to replace exercises. You can do all the big and important stuff, manual therapy and exercises, and dry needling in 1 session. I'm going to remove the needles and just put them in my sharps container. You can manipulate the needles, which we teach different techniques: tinting, spinning, periosteal pecking, pistoning. There's various techniques we can do with the needles that we teach in our dry needling certification course. Additionally, there is electroneedling, where we can take basically TENS or NMES rather. We can take TENS or NMES basically and run that current into the needles, into the muscles, and cause the muscles to pulse and twitch. It increases the treatment effect, and it can help with muscular relaxation and pain modulation and some different things like that. Not going to get into it, but that's the basics of dry needling from our perspective. And dry needling is always an adjunct. In other words, it is complementary to what we do. It's not what we do, but it helps what we do. Manual therapy and exercise is always number 1. All
I
right.
think most of the literature you look at, dry needling has good evidence when it is combined with manual therapy and exercise, not by itself. So people who just do dry needling on every patient, this is an important information. If you want to practice evidence-based practice or evidence-based research, make sure that you're using dry needling combined with other modalities like therapeutic exercise and manual therapy.
Okay.
Dr. Ford, I think we should finish with some thoracic mobility exercises targeting T3, T4, T4, T5.
Yeah, let me demonstrate those. Before my patient goes, he just asked me to manipulate. This was my deal with him. Rib and lumbar spine. Let me do that. You guys can watch. I'll let him go and we'll demonstrate just that. Come on, Ram. Usually lay on your side. Lay on your side. It's not. Yep, that's fine. Hand. Hold tight. Okay. Other side. Okay, good. And you're back. Where's the rib? Where's the rib? Where's the rib? Okay, all right. So lay on your back. Come close to me. Gonna do a rib manipulation. Tell me where it is. Right there. Okay. Cool. You're good. Thanks, Ram.
Thank you.
I'll see you next week.
Yeah.
Cheers. All right, thoracic mobility. Let me show you guys. Dr. Singh, what's the first one? Is it foam roll?
You can show the foam roll. I can go through the
Okay, cool.
presentation.
Yep.
So this is the one. And then
I
you
got
can
it.
do okay.
I got it.
Share. Yeah.
Okay, cool. You guys pin my screen, make it big. Okay. So self-thoracic mobilizations on a foam roll. If patient or if you don't have a foam roll, Byram, you can use a towel, roll up a bath towel or something and place it on the ground. We can break thoracic spine into several zones. So let's do lower thoracic spine. It's like a reverse crunch. Go over that about 15, 20 times. Let's do mid thoracic spine. And then we can do kind of upper thoracic spine. I usually tell my patients about 15 or 20 repetitions for about 5 seconds. Okay. You can use a chair. If you've got a chair that's got a back that's not too low or too high, you can use a chair. So if I sit all the way back in the chair, that's going to be like mid-thoracic. If I want to do CT junction, I can scoot down in the chair and I can fulcrum. I can fulcrum over a little bit higher up the CT junction. Okay. Other thoracic mobility exercises would be open books. Open books, or it's also called upper trunk rotations. Patient lays on their side, knees are bent, arms straight out in front. This arm comes up to here and then reaches back. I like to have my patients take a deep breath at the end. So reach up, rotate as far as you can, deep breath, fill your lungs right here. And then come back. That's good for thoracic spine and ribs as well, a little bit. The next one and last one, I believe, some call it thread the needle. You're going to take one arm, you're going to twist your spine and reach as much as you can. Reach, reach, reach. And then we're going to bring it up and reach opposite direction towards the roof. So that's it for joint work. That's it for mobility work. That's it for dry needling. Additionally, the patient would have some muscle imbalances, right? Some weakness, some tightness, some stiffness. And so there would be exercises probably for posture, for strengthening the thoracic extensors, maybe some scapular muscles like mid traps, lower traps, etc. Addressing some movement impairments, like if the patient has a movement dysfunction or they're not moving properly. But we will not have time to get into those today. I'm going to sign off. You guys have been wonderful. Thank you for tuning in. Thank you for listening. And Dr. Singh, I'll let you wrap it up.
Thank you. Thank you, Dr. Ford, for detailed demonstration. I mean, it was really good. We'll share the presentation and share the video on YouTube. And we'll also share the quiz online if you want to test yourself, how much you learn from this course. These are some of the references. I mean, and if you want to sign up for the whole program, Dr. Dhrumi will share the information.
You guys sign up. It's really inexpensive. It's totally worth it. Do a course or two with us and see what you think. But I know that you guys are going to love it.
Yep. Any questions you have? I think we'll stick around for 5-10 more minutes. Yep.
Hello. Hello.
Hello.
Am I audible?
Yes.
Yes.
Oh, thank you so much, Dr. Singh and Dr. Tejinder Singh. It was such an informative webinar. Hands-on technique plus demonstration, practical demonstration makes it different from the other webinars we attend. Because of the time constraint, we can take 3-4 questions.
Yeah.
The first question was, while manipulating any vertebra, so we should start doing soft tissue release first, or we should manipulate first? This should be done first.
I think there is no correct answer to it. I mean, as a manual therapist, sometimes you treat patients who are really, really hypomobile. I sometimes start with thoracic mobility exercises just to loosen them up. And sometimes I would do some soft tissue work, but I think with thoracic spine manipulations work great. What's your opinion, Dr. Ford?
Yeah, so most of the time I want to get the joints moving as quickly as possible. I will attempt a manipulation as long as it's not contraindicated. So I will attempt to manipulate. If the manipulation is not happening, I'll do joint mobilizations and follow that up with some mobility exercises for the spine. If my patient is having a lot of pain, then I may not, depending on the patient, right? Then I might need to do some heat, some mobility exercises, or whatever the case may be before we can actually get the manipulation. But I would say most of the time, I try to deal with the joints and get them going as quickly as possible. But certainly if your patient cannot tolerate, the manipulation position, like just putting him in the position, they're exquisitely uncomfortable or having a lot of pain, then it might be beneficial to get them to relax a little bit first. And, the other thing is, the better therapist you are, the more you can help your patient to relax into the manipulation. The less experienced you are, you'll try to force the manipulation and make it happen when the patient is guarding, when their muscles are tense, and that would be a mistake. And so I think the clinical reasoning is just there. It depends on, it's different for every single patient. It's different. You have to use your judgment and learn from experience, certainly.
So the second question was, once the thoracic, if you are manipulating T4 and T5, so there must be if it is a chronic case, there must be a compensation from the cervical as well as from lumbar area. So you manipulate cervical and lumbar area as well, or only thoracic area will do?
We're always interested in regional interdependence. And so I like in the first day or in the first 2 or 3 sessions to go ahead and clear out the region, right? We want to address the target area on day 1 for sure and get that going. If you have time in the first session or first 2-3 sessions, we do need to address the other deficits that are going to be there in the neck, in the lumbar spine, in the pelvis, and stuff like that. So I try to do as much as I can on the first day to clean out the system, to clean out the mechanics, to address the issues that are present, and then we can move on from there. So,
I think the terminology I like to use is like silent dysfunction. You can have dysfunctions which are asymptomatic, but because our body is a one biomechanical chain, we would like to address the dysfunctions that are not painful at that point of time, but that can become pain generators in future. That's how our brain works. We try to focus too much on the site of pain. So yes, we would address all the other possible dysfunctions.
Sir, could you explain the term barrier for our attendees? Barrier.
So the term barrier means that when you're trying to manipulate. So, Dr. Ford, do you mind showing, if you have a TheraBand, do you mind showing with a TheraBand what the barrier means? Just how you can go in the range, and if I can find a TheraBand, I can show you as well. Give me 1 second, okay?
okay.
So going back to Maitland's grade 1 to 5, the barrier means that if you're trying to, grade 5 means, or HVLA, which is high velocity, low amplitude thrust, means that you're manipulating at the end range. So for example, if this is my tissue, this is my collagen fiber, I'm trying to stretch it. Now I can't stretch it anymore, right? And I've hit the barrier where I can't stretch it anymore, and now I'm going to thrust it here, and that's the barrier. Okay.
The last 2 questions.
Yes.
Patient always feels better once they hear the sound. So does that pop sound matter while manipulating?
It matters, but I think we focus too much on popping, and that's where the problem is. The only significance of popping, as far as research is concerned, is that when something pops, you stop manipulating, and that's the only relevance. I always believe that a lot of us, like chiropractors, osteopaths, manual therapists, we focus too much on popping, very, very less on clinical reasoning. Because I mean, you have T4 dysfunction, you can manipulate T4, patient will feel temporarily better. But if you don't fix the secondary dysfunctions, you don't fix the neck, you don't fix the segments above and below, you don't fix the pelvis, you don't fix the lumbar spine, symptoms will come back right away. Okay, or you don't fix the muscle imbalance, then the symptoms will just come back. So the idea is popping is just a tool. Manipulation is just a tool. Idea is to understand what's going on. We always get fascinated by popping, needling. Those things are fine, but I think you have to understand what you have to do. Understanding the condition. That's why I was asking you what structure is getting affected. You need to know what is the difference between nerve root dysfunction or an axon dysfunction or a cord dysfunction. It is important to understand what you're treating rather than just focusing on popping and needling. Yeah.
Sir, in India, still the awareness about the joint manipulation is still less. So how do you convince patient for the thrust for HBT?
Can you come again?
How can you convince your patient for HBT? Because in India, they are always afraid of getting manipulated. So they have always doubt in mind that I may damage my other stuff.
Okay, so the idea is that once you've been practicing for a while and once you are really expert at doing it, you can actually manipulate with very little force. And I think Dr. Ford can answer this question really well, because you don't need a whole lot of force to actually manipulate. The problem with manipulation is that a lot of chiropractors, they manipulate at a high velocity, high amplitude. What we teach and our philosophy is to have a very low amplitude and a very little force to be able to manipulate. Okay.
Yes.
And if your patient is still like fearful or still has like a very high fear avoidance, I would just mobilize. Because yes, manual therapy is great. We want things to pop, but we also have to consider what patient's belief system is. Anything you want to say, Dr. Ford?
No, yeah. I mean, so just like in the USA, in India, here's the problem. You have people that are not well trained, that are not well experienced, or they think popping and cracking is cool. So they go and attend one weekend course and then they try to pop and crack all their patients because they've been told that, popping and cracking is like a miracle cure. And so they want to do it on everybody. And so there's no clinical reasoning. Technique is shoddy at best. And a lot of people are getting hurt, and maybe it's getting a bad reputation or a bad rap. And the funny thing is, I can go for, months, a year without having a single patient be like sore for 2 or 3 days after the manipulation or uncomfortable during the manipulation because of skill and clinical reasoning and stuff like that. And so that's what we're trying to bring to the table. It's the technique is easy on somebody who does not have pain and who does not have a problem. But when a patient has pain and has a problem, the clinical reasoning must be there. And that's what we aim to impart. So it's not just everyone going around popping and cracking stuff. So I would say that if you have a patient who's apprehensive, you could always do a manipulation that's like away from the site of where they're having pain or discomfort, and just show them, this is basically what it is, and it's not that bad. Or let me do some mobilizations. Once in a while, you do have to educate a patient, like, this is going to be uncomfortable, but if we can get it to pop, if we can get it to move, you'll feel better. Like within a day or two, you'll be feeling better. And so it's worth it. Let's try it. Let's try it one time. If you don't like it, we can do something else. I think there's a variety of different ways to put the patient at ease. One of the biggest ones being your hands. If you're confident and comfortable and precise with your technique, the patient can relax. But if you're shaky and you're apprehensive and the patient's apprehensive, then that's just not going to go well. And that's the difference between a basic manual therapist and an expert manual therapist. That's why we can't teach everything online. We'll show it, we'll demonstrate it, but we've got to be there for hands-on training, so that we can give feedback. When I was there in Mumbai and Delhi earlier this year, I was on tables. I was laying down on tables and I was having people practice on me so that I can give good feedback. Well, this feels like this feels like that. And, for Dr. Singh and I to be able to watch it and feel it and see it, we can offer optimal feedback, which is, I think, one of the things that makes us different. We're not just going to, teach it to you and expect you to figure it out on your own. We're going to guide you through that process. And it's a journey. It was several months probably that I practiced neck manipulations before I became proficient and very comfortable with them. And some techniques are easier than others and stuff like that. But yeah, I think it's a multifaceted problem. And I think the best thing you can do is just put your best foot forward and practice as much as you can. Don't force manipulations on patients that don't want it. It's frustrating, but don't force them on patients that don't want it. You can try to educate them, but the decision is theirs. In the end, the decision is theirs, because if you start manipulating them against their will, they're going to be afraid and they're not going to come and see you, right? The other thing I would say is practice your manual therapy techniques on young, healthy individuals, because they'll take the manipulation better, and they'll have good joint mobility, and you can hone your technique on healthy, flexible individuals, and that'll make it easier for you when you've got a person who's got pain or is a little bit more complicated clinical presentation. So yeah.
Thank you so much, both of you, for your lovely insight. Over to you, Dr. Pratiksha.
Good evening, everyone. It has been such an honor to be a part of this wonderful event. On behalf of the Indian Association of Physiotherapists Thane District team, we would like to extend my heartfelt gratitude to our esteemed speaker, Dr. Stephen Ford, and Dr. Tejinder Singh, for accepting our invitation and for being here with us today. Every one of us learned a lot today. Thank you, Central IIP team, for providing us such a great platform. Thank you to Dr. Uttam Mohan ma'am, IIP Digital team, for your technical support to host the program online smoothly. Thank you, State IIT team, for always supporting us. Special thanks to Dr. Bharti Dave ma'am and to Dr. Mansi ma'am for to be a pillar of our IIP Thane district team and present today for this event. Thank you everyone. Sincere thanks to everyone who handled the event throughout. A wide round of applause and thanks to all the participants who made the event a memorable one. Finally, I would like to thank all of you present here for making the time to be with us today and helping us make this event a grand success. Thank you, one and all.
Thank you, guys.
Thank you so much. We'll see you guys next time.
Sure, sure.